Good afternoon, everyone. Thank you so much to the network for inviting us to come and talk to you this afternoon about the programme of work that Iris and I and others across the North West are engaged in, really looking to harness lived experience and life experience at the heart of our teams. My background is I'm an occupational therapist. That's my professional background. And I work for Mersey NHS Trust as their allied health professions lead, but also as their trust strategic recovery lead. And I also work for an organisation called ImROC, which, for those of you who haven't come across it, it stands for Implementing Recovery Through Organisational Change. So ImROC is trying to work with big organisations like Mersey to help it think about how it structures itself, how the system changes to support recovery for individuals. So hopefully we're going to try and connect the role of the peer worker in terms of those structural and system-based changes and bring it back to the 5-year forward view. So I'm going to hand over to Iris now. I'll tell you a little bit about her background.
Hi everyone, and oh gosh, it's great to see some great faces today. I know some of you here who have had me helping them with little bits of things. My name's Iris, as you can gather, and I'm an expert by experience. Actually, I'm not an expert in anything. I'm a person. I'm me. I work for ImROC as well. I work alongside Lynn and so many other professionals and service users and carers who have all been on my journey with me and continue to be on my journey because I'm still in services. I'm still a patient. That's quite a long title, isn't it, really? And if you think you put it alongside my diagnosis, my goodness me, wouldn't I need a big badge? I've had a few diagnoses. I collect them. I also challenge the stigma, and I've got a huge T-shirt. I didn't realise how big it'd need to be. I've collected a few psychiatrists and diagnoses, of which are on the T-shirt. And actually, it's got every one of them collected over about 30 years, and there's quite a few. And on the bottom it says, actually I'm a person, I'm me, I'm just me. And on the back it's got MAD. Mad means making a difference. I've been called a lot worse, so I think it's okay to be called mad. And I think we should all have a little bit of that and acknowledge that, you know what, it's okay, to be different. I'm not different, I'm a person, I'm a human being. And what I heard this morning when I came in, how powerful. We need to give everyone a voice. I've been given my voice back. I think someone wants to put me back on my medication. I'm still on my medication, but I can speak now and I'm grateful. I've had a lot of psychological interventions. I work with some psychologists on the DCLIN course. I'm proud to do that. And the therapy has accompanied a lot of other things like my medication, all of that to get me where I am today. And I'm proud to be here. So thank you for inviting us.
Okay, well, one of the things at the heart of the 5-year forward view is this term we call co-production. And Iris and I work hard back in Mersey and through ImROC to really try and authentically co-produce the work that we're doing. So we're going to role model co-delivery of this presentation, and we've spent quite a bit of time working out the key messages together so that we harness both sets of expertise today. Okay, so any one of us could be affected by an unexpected life event or illness where peer support will be vital to our recovery and well-being. And for those of you who have read the 5-year forward view in detail, peer support is in the top 10. In fact, it's in the top 3 categories of things that will really have a big impact on services and the system in terms of transformational change. So by harnessing the knowledge and expertise and commitment of people with lived experience to support one another, mutual peer support has been shown to really improve outcomes in terms of people's recovery. However, currently these roles lie at the edge of our system there aren't enough peer support workers or peer tutor roles in the system yet to really start to see a significant change in outcomes. And so in terms of the North West, we're going to try and describe some things that we're putting in place at the minute across the region to help develop these roles more significantly.
Okay, so peer support workers are powerful recovery role models who have lived experience of mental health issues and actively use those experiences as a way of support to others, whilst continuing along their own journey. And I believe our Chief Exec wants at least 50% of our workforce to share their lived experience. I haven't got a problem with that. I think it's a really great idea, but I also think we need to look after our staff and our service users with lived experience to, first of all, want to share their lived experience, and it's okay to do so, but also to get the support and the guidance to do so. Because otherwise it can flood people if it's their first time they've ever shared lived experience of abuse or whatever. And it's okay not to want to share it too. You know, we shouldn't be forced into anything we don't want to do. That's damaging and cruel. So we need to make sure that we support our workforce if that's what we're going to do. But I'd love to see it. And I work alongside a lot of staff that do share things with me. And I'm a PD person. Yeah? But next time someone calls me a PD person, can they put the MBE on it as well? I'm not a PD person. I'm a person with a diagnosis of personality disorder and DID. Right? And I've had so much help of people like Lynn and so many other professionals, but we need to look after you too. Having peer support workers within the workforce brings a unique element to the service through equal... Go on, you say it.
Reciprocal.
That's it. Sorry, I always get it wrong. Relationships they provide. This is co-production. So in the relationships they provide hope. Without hope, we have nothing. You know, give people hope that moving forward is possible, and it is. I'm living proof that it is. They also feel belief that recovery is possible. And recovery is a big word. Don't mention recovery to the DWP, please. I've had experience of that. We all recover at a different rate. We're all individuals. We all have our individual recovery. And some people like me can go as far as this. I've been fortunate. Some people may not be able to do this and may not want to do it. So we have to be, it's an individual process. And it is individual. And it has to be at the right time for each individual. Can't force it. And we can't rush it either. Okay.
So at the minute across the North West, different organisations are at different places in terms of introducing these roles into teams. And what we did back in March was bring all of those organisations together with Juliet from Health Education England to have an initial workshop to share what all of the mental health organisations were doing across the North West, and to build momentum, really, to bring a network together to support one another and put an action plan together and some terms of reference for the network, really to support and grow this workforce across the North West. So the network has probably met 3 times now, including that workshop in March, and it's started to develop standards, and it's commissioned an accredited peer support worker programme to run in January, probably twice, so that organisations can support those people from their organisations who are interested in doing the course, to support them to do this role in practice and to gain the qualification. The course is at level 4, so it's at degree level, and people gain 20 credits. But it's kind of the building blocks, really, in terms of supporting people to do this role in practice.
And it can be done. I've no education. I didn't go to school. I passed the peer support worker course. I had to ring the university to check it was okay, because I didn't believe them. That's my first ever certificate. And so it can be done. And just before we carry on, I just wanted to say my lived experience was absolutely appalling. And I never ever dreamed of having a life like this. And I used my lived experience because I didn't know what to do with it. It was destroying me. I had loads of psychotherapy and everything. It was absolutely destroying me. But then I thought, no, you're not going to destroy me. My mother's not going to destroy me for abusing me. Those other people aren't going to destroy me. I'm going to use my experience to help others to get the help they need through psychotherapy, through mental health services. We all have a part in someone's journey, and I'm grateful for that. So.
Cool. Okay, and also the network has some funding available to it to look to further the evidence base around these roles. There is a significant evidence base growing, but we want to kind of further that evidence base in the Northwest. So we've talked about the regional approach. What does this mean for organisations? We're going to try and talk to you about our experience so far in Mersey Care. And obviously the 5-year forward view sets out kind of a series of key steps around transformation. In Mersey Care, obviously we've got our own strategy around what that means in practice, and it's key to make sure that these roles are embedded in that strategy. So Mersey Care's strategy is one where we're striving for perfect care. We haven't got there yet, but we've got audacious goals to be perfect and describe what perfection looks like. And obviously, enhancing our recovery college and peer support worker programme underpins that. And these roles don't work in isolation. In terms of ImROC that I mentioned earlier, Mersey Care has been engaged with ImROC for a number of years now, really testing out 10 key organisational challenges that underpin recovery for individuals. So for us, peer support workers and developing those roles sit around 4 other key strategies. And from using the 10 key organisational challenges, as we've grown and developed more expertise around those challenges, these are the 5 key areas for us in Mersey Care that really make a difference. So it's selecting, training and supporting peer support workers to shift the culture. The application of recovery principles to improve the quality of care and safety on inpatient units, so reducing restrictive practice, and our programme of work is No Force First. A move from professionally determined risk assessment and management to person-centred safety planning. Streamlining routes to employment and meaningful occupation, and the establishment of a co-produced recovery college, empowering self-management and learning.
I actually lead as a service user care rep, expert, spy experience, all of those things. We actually work together to help, and I'm leading on our No Force First strategy. It's going really well. It isn't easy. Lots of people are very risk averse with people like me. People who understand that will know exactly what I mean. And I also lead on values-based recruitment, not because our staff don't have the values, they very certainly do. We can't go in there and say, we're going to teach you a new thing about values. You've got them in, I can't put into words how much you've got values. So I don't think that's a good way of approaching people. But working together, co-producing things, harnessing everyone's strengths. And I mean, I can't explain how working together has made my life change. Someone's given me a chance of being a person and having brains, and I love that, because I never was told I'd never get any and I would be never give you any use. Well, you know what? They were wrong. We can work together.
For those of you who haven't visited the ImROC website, I'd advise you to go and have a look, because it's got so many useful products and briefing papers, and these are 2 that are linked to peer support. And really what the briefing papers do is they give you the evidence base and where people have tested these roles out in practice and the difference that they've made. And basically kind of peer support work as a co-production in action. What we're talking about is 80% of roles working alongside professionals in teams, but others as peer trainers in recovery colleges, and delivering peer support through an educational route.
And don't forget, this is a journey. So in Mersey Care, we have volunteers, And we have people who want to, user experience, and it's called inclusion, which is great. It's a journey. Everyone can have a chance of doing or going as far as they want to. Yeah, and I started off years and years ago as a volunteer, and I loved it, and I still volunteer. But my passion is people. I love people. I've had so much help, and I'm not being patronising or soppy. Well, I am being soppy. I am soppy. Someone told me to stop being soppy, and I'm not going to be, so there you go.
And the evidence base suggests the impact of peers is fivefold. So there are benefits to the peer support worker in terms of being able to use their lived experience to make a difference to other people. And that might be good and bad experience of the system, but usually it is of navigating the system that sometimes is very, very hard to navigate.
And not just for us, systems like you guys down too. It's not. We're not all to blame. We work together. You work together, then we can challenge those systems, and I do.
Benefits to the people being supported. So Iris quite eloquently illustrated hope, but also giving people back control and opening up opportunities for a life beyond illness. The key tenets of recovery. There are benefits to the organisation and shifting the culture and the focus around recovery at the heart of our teams. Benefits to the teams in terms of thinking about harnessing lived experience in everyone, not just formal paid peer support. And in terms of the cost effectiveness, Centre for Mental Health looked at a number of studies, particularly linked to lengths of stay and bed occupied days, and the mean average benefit for employing peer support workers is 4.76. So generally, by employing peer support workers, you save 4.76 of their salary in terms of in the system. So linking that to your transformation programme really is key. So this next slide just illustrates the model really in terms of introducing roles into an organisation. So there is preparation, preparing the organisation for these roles. What do they mean in practice? What do the roles do? Preparing teams. The evidence suggests that if you place peers into teams that aren't already recovery focused, then this fails. So you have to formally do something with the teams to make sure that they're very much focused on recovery. Defining roles and developing job descriptions, preparing the peers, so their learning and development and that accredited peer support worker course. And then obviously you need to go through a recruitment process, so advertising, working with people who are terrified of the benefit system and what this might mean, supporting people to put applications together through interviews, working closely with occupational health departments in terms of screening and checks, CRB or DBS checks and what might show up when you're recruiting people, and finding solution to those issues. And supporting those people who might not be successful straight away, getting a role. They might not be ready now, but what do we need to put in place to support people so they are ready in the near future? And then obviously going through employment, so matching roles and peers to teams. And also the evidence base suggests that placing peers in isolation also doesn't work, so placing peers with another peer in a team works better. Supporting people through their induction and orientation phase, supervision and support, and maintaining well-being. And then obviously ongoing development of the role, so where you might introduce peers, where's the career progression for people past those roles, and why does system change? I'm not going to talk too much about this slide, but this is just an example of where we've got peers really making a difference through the criminal justice system. And then I'm going to let Iris finish in terms of what this is making, the difference this is making in terms of people who are using our services.
And I'm honoured to read this for another service user that's not here, another peer. I thought it would be right to give a special praise to my peer support worker. From the moment we met, I had finally found someone who I could talk and confide in, who actually knew what the pain was like. No disrespect to the staff, but unless you have been there, it's not something you can easily pick up from a book. I think the peer support workers are a great idea and an asset to the NHS, as I believe my stay would have been much longer without this support. And I agree with that. I was, my first, well, I've had loads of jobs, but in the mental health system, my role was that revolving door patient. I was in and I was out and I was in until, and then I got therapy, that helped. Lots of things helped. Other service users and carers, staff that have nursed me, put up with me, being so poorly, and they must have got so despondent at times when I returned back on the ward, despite them doing all those good things with me. Everything helped me. I've been so fortunate to have all that stuff. And lastly, please, when you speak up, make sure, and we need to speak up, because if we don't say what's wrong, we can't make it better. We shouldn't be blaming people. Systems often let us down. But we have to enable and support our staff and our service users and carers and peer workers to say if something is wrong. But we need to make sure that they're fully supported when they do that. Otherwise, they suffer. I've seen it happen in lots of other places. And if the government wants to say and whistle blow or raise concerns, call it what you like. Yes, do that. But make sure you have full support, or it will make you unwell. And I will advocate for every single person. I was at Signet Health on Monday, and a social worker spoke up who'd been struck off for doing just that. And I don't do hugs. I don't do hugs very well because of my history. But when I'd finished answering my questions that day, I went over and gave her the biggest hug ever more because she was so brave. But we have to make organisations realise that is a brave thing to do, and it's a real hard thing. We need to support them. So thank you so much for listening to us today. If you want to talk to us, we'll be here for a while longer, so thank you.